Thank you for introduction, and dear colleagues and friends. First, I would like to thank Professor Sanjay for the invitation. And in my speech, I will try to analyze the situation with the hepatitis delta epidemiology and treatment. On this map is the worldwide prevalence of HDV among HBV carriers and their genotypes. And as you see, the problematic zones is Mongolia, Pakistan, Central African Republic, Western Amazon, and Kiribati Islands. And now I want to tell about the countries that had previously very scarce information. They are the countries of the former Soviet Union, and the area that I will be discussing is displayed with the mark no data. It is possible to, I want in my speech, I will use the materials was obtained from the APASL single topic conference dedicated to Delta hepatitis in 2019 in Baku. And it is possible to distinguish two major endemic zones, Romania and Moldova, with a high prevalence of HDV, and at the same time, is situation any better in the neighboring countries? Let's find it out. At first, Russia, with a population of 106, 146, 47 millions, and a result of the old study in 2010-2012, prevalence of hepatitis delta in eastern part, some areas of eastern part of Russia were very high. You see that Chukotka 30-31%, Sakha 24.5 to 31%, Tuva 22.6%. On the other side, western part of Russia has very low percent of HDV, except the big industrial cities such as Moscow 19.5, Samara 39%, and Astrakhan 10%. And as can be seen on the map, according to the publication from 2019 by a large study group, a huge part of Eastern Russia, as the same, is characterized by a high prevalence of hepatitis delta, 21 to 60%, compared to the Western part, where the prevalence is varying between 6 to 20%. Another country, neighboring country, Belarus, with population 9.5 million, and in Belarus, an old study revealed a low percentage of hepatitis B patients, or about 1%, of which 8.9% were patients with hepatitis delta. But we have any novel information about the prevalence of hepatitis D in Belarus now. Another country is Moldova, with population 3.5 million, and here you can see the points of epidemiological data for HBV/HDV in this country. As you see, in 1994, immunization of infants against HBV at 0, 1, and 6 months was added to the Moldovan National Immunization Program, and since 1998, at least 89% of the 1-year-olds have received 3 doses. In 1997, vaccination of risk groups such as medical workers, medical students, family members of people with chronic hepatitis, hemodialysis patients, sex workers, and drug users was begun. In 2012, the incidence of acute hepatitis B was 1.54, and of acute hepatitis D 0.15 per 100,000 population. And frequency of HBs antigen detection varies around 2 to 9%, and risk of infection on lifetime is 20 to 60% for all groups of population. And 27% of HBs antigen positive subjects are about 1,700 new HBS carriers, 3,000 deaths, and 200 disabilities, including liver cirrhosis and hepatocellular carcinoma, are reported every year in Moldova. In this slide, you can see 3 decades about hepatitis delta in Republic of Moldova. In the first decade, when the screening program applied and every second positive HBS antigen patient was tested, we have and they had a very high level of HDV, but the situation changed in the second decade, where the universal vaccination program applied, but decreased on the same time, decreased the viral hepatitis D screening, and HDV has been recognized as a rare disease. And as a result of this, in the third decade, some causes such as a reduction of HBV vaccination, reduced viral hepatitis D screening, the widespread use of drugs, the intrafamily pathway of predominant infection, legal and illegal immigration of infected people, increased again the level of HDV infection. And basically, 70–80% of the infected are unaware of their HBV positive status, undiagnosed in the early stages, and only 1/4 of them are found in late stages, F3, F4, the compensated liver cirrhosis and hepatocellular carcinoma. Another country is Ukraine, with population of 42 million. In Ukraine, study was conducted among healthy donors, and from 2004 to 2007, a low level of HDV infection was detected, but the situation is currently unknown. Now about the Central Asia, these countries as Uzbekistan, Kazakhstan, Kyrgyzstan, Tajikistan, Turkmenistan, and you see that there are different prevalence of HDV in these countries. First of all, Kazakhstan is the largest country in the region with population 90 million. And in this country, from 2012 to 2016, the prevalence of hepatitis B has been steadily declining, which is the merit of regular vaccination of children and adults, as it seems to me. However, paradoxically, over the same period, the number of patients with hepatitis D, on the contrary, becomes larger. In my opinion, this is primarily due to a more attentive approach to the disease and better detectability strategy. Ways, as you see, most of them medical operations, 30%, stomatological manipulation, 25%, and blood transfusion, 7%. And only 3% of safe sexual contacts, 5% drug abuse, and unknown ways. Another country, Kyrgyzstan, with 6.5 million population. Epidemiological data consist only of acute cases of viral hepatitis, and on this list, hepatitis D is detected only in 2% of cases. Uzbekistan, with 33.2 million population, despite high prevalence of HBV infection, data on hepatitis delta was lacking until 2019. And already in 2019, anti-HDV positive patients were identified in various regions of Uzbekistan. So in Tashkent, the percentage was 12%, and in Termez was 14%. Another country, our neighbor country, is Georgia, with 3.7 million population. And here you see findings from the National Seroprevalence Survey, and the national prevalence of anti-HB core and HBS antigen positivity among adults were very high, 25%, approximately 25–26%, and 2.9% respectively. And among HBS antigen positive persons, just 0.9% were HDV co-infected, very, very low level. Now about my country, Azerbaijan. with 10 million population, and this map shows the frequency of detection of hepatitis delta in various regions of the country. The largest number is in Baku, in capital city, but I believe that this is the result of more detailed detection rate in this city, comparing to healthcare providers from the region. In 2019, we provided a small multi-center retrospective study, and 2,169 patients with chronic hepatitis B were admitted to clinics during 10 years, and hepatitis delta co-infection was detected among them approximately 12% in 12% of cases. At first admission with advanced liver disease, compensated cirrhosis were admitted 42% of patients, with one and more episodes of hepatic decompensation 27%, and hepatocellular carcinoma 2.3% of patients. Transmission ways were the most of causes was hemotransfusion, 34% narcotics, 24% surgical operations, 16%, other manipulations such as stomatological, gynecological, and others, and unknown causes at 18%. And it should be emphasized that HDV is not only a demographic, it is also a social problem. As you see in this diagram, young people from 20 to 50 years old with active delta hepatitis shows that from 31 to 57% of them have advanced liver damage or cirrhosis. And at the age of over 50, this percentage is already over 80%. And this should help specialists to spread information that will help to diagnose and find new methods of treatment for this threatening disease. And now about life cycle, because if we want to tell about the treatment, we should know the main principle of HDV replication. HDV is the smallest known human RNA virus and is defective RNA virus, which requires HBs antigen for its replication. Entry of HDV RNA into hepatocytes occurs through binding of NTCP receptor through the pre-S1 region of the large HBs antigen. Replication in double rolling cycle, and rolling cycle replication allows for transcription of full-length antigenomic RNA, which is used to generate genomic RNA through the assembly and prenylation. And currently, there is no treatment approved for chronic HDV infection. Current guidelines of American Association for the Study of the Liver, Asian Pacific Association for the Study of the Liver, and European Association for the Study of the Liver recommend pegylated interferon alpha for 12 months and maybe longer. And pegylated interferon as only treatment option, but limited treatment efficacy, just CVR maybe in 0 to 47% of cases, long treatment duration 48-96 weeks, poor tolerability. And to study HEDIT-1 and HEDIT-2, you can see the results of this study that suboptimal due to significant side effects included cytopenias, limited efficacy, and high long-term relapse rates. Novel treatment options have been evaluated recently, and 4 areas of interest include specific inhibitors of HDV prenylation, this is lanafarnib, HDV entry inhibitors, bulevirtide or mercludex, inhibitors of virion secretion, Replicor, activated the immune host response, interferon lambda. And the CP receptor was identified as the specific receptor for HBV and HDV. And bulevirtide, a synthetic pre-S1 derived peptide, has been identified as anti-CP receptor inhibitor with little effect on bile acid transport. And this peptide discovered by Professor Urban, University of Heidelberg, Germany. And this is the main points of bulevirtide. Monotherapy with bulevirtide is a safe and promising strategy against HDV infection, and Russia now use this drug for treating the HDV infection. Combination therapy of bulevirtide plus pegylated interferon alpha may induce cure of HDV infection. Combination treatment will be evaluated to induce functional cure in HBV monoinfection, but is very expensive, dollars per month. In 2003, interferon lambda, a type 3 interferon, was discovered and was subsequently studied as an alternative treatment to interferon alpha in HCV and HBV infection. Prior studies have shown that interferon lambda has similar downstream signaling pathway to interferon alpha, but interferon lambda signaling is localized to the liver, and interferon lambda may have a protective role in the liver. And in a multi-center randomized open-label phase 2 trial, the safety, tolerability, and efficacy of interferon lambda was evaluated in 33 patients with chronic HDV infection, linked mono HDV. Patients received interferon lambda 2 doses. 120 microgram with 90 patients and 180 micrograms, 14 patients in group. Subcutaneous weekly for 48 weeks with 24 weeks follow-up. And patients also received tenofovir or entecavir for HBV suppression, and the primary endpoint was change in ADV RNA from baseline to week 48 and at week 72. Responders were defined as those exhibiting a too log decline or below limit of quantification of HDV RNA. Interferon lambda was generally well tolerated, and patients that received prior treatment with interferon alpha reported fewer side effects with interferon lambda. And a durable virological response was achieved in 36% in the high-dose interferon lambda cohort compared to 16% in the lower dose cohort. And this was maintained in both groups at 24 weeks follow-up. And by the end of the follow-up, ALT normalized in 36 vs 26 in the high vs low dose cohorts, respectively. As mentioned previously, HDV replication is promoted by small HD antigen and inhibited by large HD antigen, which promotes assembly and export HDV through prenylation of large HD antigen. Lonafarnib is inhibitor of prenylation and prevent the production of HDV variants. A proof of concept phase 2 trial assess the safety, tolerability, and effect of HDV RNA levels of oral lonafarnib in chronic HDV infection. 14 patients were randomly assigned to receive lonafarnib 100 milligram or placebo, and this is first group, or lonafarnib 200 milligram or placebo group 2 for 28 days with follow-up for 6 months. And adverse effects, including nausea, diarrhea, bloating, and weight loss, were notable in group 2 with high dose of lonafarnib, but treatment discontinuation was not required. And here you see the results of study with combination treatment, lower HDV2, where the lonafarnib were combined with ritonavir and pegylated interferon alpha. And these two groups compared with he did two study where the pegylated interferon 180 micrograms per week combined with tenofovir. And as you see on this diagram, the low dose lonafarnib and ritonavir as the same give the same result as in he did pegylated interferon plus tenofovir, but combination therapy of these three medicine give a very show the high efficacy in the treatment of HDV infection. Another group used for treatment of HDV are nucleic acid polymers. And they are the oligonucleotides with the broad spectrum in vitro antiviral activities reported to act via entry inhibition in other viruses and also proposed to bind to amphipathic protein structures. And these amphipathic protein structures are common in viral proteins, but are also found in key host cell proteins. Replicor 2139 developed to address tolerability issues with Replicor 2055, used in Bangladesh by Professor Mamun Al-Makhtar. And but there is the result of a small study in Moldova with 12 patients, HDV patients with positive anti-HDV and RNA with HBs antigen quantitative more than 1,000 and non-cirrhotic. First 12 weeks, patients received 500 milligram intravenous of Replicor. The next 12 weeks, 250 milligrams intravenous with combination with pegylated interferon. And last 24 weeks, only one pegylated interferon. And as you see, 4 from 12 patients reported to have impressive drops in HBs antigen at week 15 and associated with HDV RNA negativity. And potential study, LIFT study, is combined with lambda interferon with ritonavir and lonafarnib. And now we wait the result of this study. And the future treatment options are some combinations, such as pegylated interferon with bulevirtide and NUC, pegylated interferon lambda with lonafarnib with NUC, or pegylated interferon alpha with NAP and NUC. And now all of these schemes are in the research investigations. And now conclusions. There are few available publications on HBV epidemiology. Some of them are outdated and some data are contradictory. The data of hepatitis D is very poor or lacking at all. In all the countries under discussion, the incidence of acute hepatitis B has decreased tenfold over the past 20 years as a result of large-scale vaccination programs among newborns, adolescents, and adults. And data from areas bordering high HDV prevalence countries such as Moldova, Mongolia, and Pakistan is controversial and confusing. This is, as we think, lack of the cause of updated epidemiological data. No national routine surveillance for HBV plus HDV infection, no national registry for Delta hepatitis, lack of strategy for diagnosing patients with hepatitis B plus D, and the population at risk is not properly identified, and we need, of course, to develop new effective therapy to HDV. HDV, fascinating collection of biology and important cause of human viral hepatitis, most severe form. Study of HDV life cycle has identified many potential host targets for antiviral intervention. Several form the basis for drug antigen secretion, interferon lambda signaling. Several drugs have demonstrated clinical efficacy, most advanced now in phase 3. Potential for combination therapy with drugs, each determined to be safe, demonstrated to have significant anti-HDV activity, opportunity to bring a significant clinical benefit to patients with most severe form of human viral hepatitis. And we wait, beginning of new era, much to be done. Thank you for attention.